So thank you. I want to thank the program committee for this invitation. And I also do want to say that I had the privilege to be at the ISCoS meeting in 2000, 18 years ago. And at that time, I don't recall many posters or abstracts or lectures on pediatric spinal cord injury. And the field has come a long way in 18 years. And today I'm really lucky and privileged to present the work of all of you in pediatric SCI in this room and not in this room. So this isn't my work. It's really the collective work of all of us. So thank you. These are my disclosures. And so, pediatric SCI is a huge topic, just like adult with spinal cord injuries, right? And so I kind of defined the objectives as the following: to describe the unique features of pediatric spinal cord injury that perhaps we don't appreciate and we don't see in adult management, including growth and development. I'll talk a little bit about epidemiology and medical complications. And then I'm going to spend a little bit of time discussing some concepts that inform or help to inform the management of children living with spinal cord injury, specifically around musculoskeletal conditions and complications, mobility, walking, and upper limb function. And I'm going to finalize and finish my talk by throwing some challenges to the field that I believe pediatric spinal cord injury is ready to embrace and carry. And so when we think about the management of children living with spinal cord injury, we really hold very close to our heart four concepts: preserve, prevent, promote, and anticipate. And why those concepts may resonate with those who work with adults with spinal cord injury, they're particularly important for those working with children. And that's because children live relatively long lives with longer exposure to the secondary complications. And so this, while it's fantastic that they're living relatively long lives, it certainly complicates the management as they grow up and move into young adulthood. And so in pediatrics, we adopt this concept as anticipatory guidance, where we anticipate future situations, changes, we anticipate complications, new presentations based on what we know and perhaps more importantly, what we don't know. And so there's ongoing education and preparation and dialogue with the child and the family about what is known and what is not known. And we importantly contextualize change that children go through as natural transitions and not failures. And this is really, really important because the functional abilities of children over time do change. And one of the most common of these changes is when children, when they're young, they're engaged in upright mobility, whether it be with FES or orthotics or any type of exoskeleton. But as they move into their teenage years, there is a natural progression where they want to be in chairs so that they can keep up with their peers and be more efficient. And it's important to acknowledge early on that this transition will likely occur and is not a failure. And then in anticipatory guidance, we also want to prevent barriers to future possibilities and treatments. And again, this is very important to be very prudent in our interventions with children so we don't block opportunity for the future. So what are the unique features of pediatric SCI? We already talked about they live relatively long lives and are exposed to secondary conditions, but they're also exposed to the treatment of those secondary conditions. And again, while those treatments are intended to help, the exposure has some risks. There's always risks and benefits. And children with spinal cord injury certainly age prematurely. There's this complex interaction between growth and development and secondary complications, and we'll talk a little bit about that. And then with children, we always have to approach our management from a developmental perspective, cognitively, physically, and psychologically. And so with respect to cognition and cognitive develop, young children have yet to develop full expressive and receptive language. And so they're unable to fully engage in shared decision making. And this ability they acquire over time. And again, we need to be careful about some of our interventions in our programs when children are not fully engaged in shared decision making about that. And children cannot report on their health status until about 6 to 8 years of age. And so we don't know when little children are in pain or may be experiencing headaches with autonomic dysreflexia. And children are learning cognitively, right? And so when we talk about prevention for pressure injury and bladder and bowel management, children learn, and we can't expect them to fully embrace that until they're able to learn fully about again, the risks and benefits. And importantly, the ability to reason and compromise sometimes really isn't developed into full adulthood, right? And so management of children and what they decide to do is all about reason and compromise. And so this is seen in typically developing children where the little guy on the left, we're asking him to pull up his pants and he gets off the chair and he's looking at you and he doesn't want to pull up his pants. And so we see this in kids, and it's no difference in kids with spinal cord injury. And so it creates a challenge around the management. In terms of physical development, we always think about size and weight and the physiological implications such as heart rate, blood pressure. We're going to be talking a little bit about metabolic syndrome and nutrition, including malnutrition, and then the musculoskeletal changes, including neuromuscular scoliosis and hip dysplasia. And then importantly, children are developing psychologically, and the most important thing in childhood into adolescence are peer groups and friends. And one thing we need to do in pediatric spinal cord injury is to make sure kids have friends, whoever they choose those to be, because they play a huge role in self-identity. We have to think about the transitions through the lifespan into young adulthood. And children with spinal cord injury are at a very high risk for developing or adopting what we call the sick role, a sick role identity, because they are chronically in and out of physicians' offices, rehabilitation therapies, and so we have to be careful. And I had the privilege to listen to Molly McCulley Brown, who is a young woman with cerebral palsy. And she is an English professor and a poet. And I was at one of her lectures as she talked about this essay she wrote, "Something's Wrong with Me, How Shifting Language of Disability Shapes Our Selfhood." And she said, "Earliest lexicon I remember having available to use to define myself is a medical dictionary of defected and attempted repair, neurological disorder, spasticity, impaired fine motor, orthopedic surgery, gait training, gait maintenance, orthoses, find all across the reference under deformity, deficiency, and disability." And if you think about how we manage children who are injured young and move them through their lifespan into young adulthood, they are chronically in the medical model. And so I think this is really, really important to understand that children are exposed to our language and our well-meaning interventions, but we need to think about how they process that and how they use that to develop their self-identity. So let me just briefly talk a little bit about epidemiology. There's little, if any, well-defined population-based studies of children with spinal cord injury. In the United States, approximately 20% of all spinal cord injuries occur in children or adolescents under 20 years of age, and approximately 15,000 children are living in the United States. These figures are slightly higher than those reported from Canada and Finland. However, it was fantastic to see yesterday in our pediatric pre-course that the global mapping efforts that's been really catalyzed by ISCoS is being done in pediatrics. And so this is a hard slide to see because I snapped it yesterday in our pre-course, but this is global mapping of pediatric spinal cord injury, and it's a publication under review. And there's a poster at this meeting, poster 114, that can talk about the global epidemiology of spinal cord injury, again, which we don't understand fully. We do know that in children under 13, there's a 1-to-1 male-female ratio, and as children age beyond that, we begin to see the 4-1 male-to-female ratio. Etiology of traumatic spinal cord injury varies as a function of age and region, although motor vehicle accidents are still the primary cause, ranging between 50 and 80%, followed by violence, falls, medical, surgical, and sports. Now, there's some unique etiologies that we see, etiologies of pediatric spinal cord injury in children, including birth injuries, sciura, transverse myelitis, fibrocartilage emboli, lap belt injuries. And then in high cervical injuries, we see occipital cervical dissociations. So I'm just going to go over a couple of these. Sciura, although we have advanced imaging techniques, we see sciura clinically and we use that terminology and we see it in the literature. And it's spinal cord injury without evidence or fracture of dislocation using these radiographic tests. In children, there's usually a history of no traumatic event or a very minor traumatic event. For example, a little somersault off the lap of a parent. We usually see a delayed onset of up to 4 days with transient paresis during those days. In children, the MRI findings can range from normal to complete transection, and there's a 48% mortality rate in children when sciura occurs in the cervical cord. And you could see that sciura is at younger children are at a much higher risk for sciura, as shown here. Now, acute flaccid myelitis is something that comes in waves and flows, and we're seeing a wave in the United States at least, and it presents as sudden weakness in one or more arms or legs, decreased muscle tone, absent reflexes. There could be some involvement of the cranial nerve. And what's important, in 2016, the United States Center for Disease Control said, there's a serious illness that causes paralysis in children, and we still have a lot to understand about the causes, risks, and outcomes. And so the etiology is thought to be enterovirus, West Nile virus, or herpes. The presentation is typically a median age of 8 years of age. And importantly, the prognosis, 2/3 have some improvement, 1/3 have no improvement, but no one fully recovers. And the American Association of Pediatrics just recently published this paper, No Common Etiology Treatment Found for Acute Flaccid Myelitis. Fibrocartilaginous emboli is another etiology of pediatric adolescent spinal cord injury, and it presents as sudden onset of pain with, again, delayed neurological impairment and imaging findings. And again, there's a history of minor trauma or a physical effort. So 6% of spinal cord infarctions in children are caused by this, and often seen in teenagers after reports of heavy weightlifting or a strenuous sprint. Recovery can be on a continuum of full recovery to tetraplegia to death. What we do know is the maximum recovery after this is realized soon after the incidence, and there's no studies on the prevalence of reoccurrence in children who do recover. Lap belt injuries is another unique element etiology of children's pediatric spinal cord injury, and 75% of these injuries are associated with rear seat passenger and a seatbelt sign. And the only message here is typically the seatbelt sign, there's a lot of intra-abdominal injuries, and the child's taken to the OR pretty rapidly, and if there's no time to clear the spine, the assumption should be that there's a spinal cord injury, because what happens is sometimes the kid's taken to the OR for the intra-abdominal injuries, which is corrected, and then the spinal cord injury actually occurs during transport because it went unrecognized. In terms of occipital cervical dissociations, and again, I think this is important because it's unique to children, but if you see up here, this is out of the book by ISCoS, but you could see the first two are, the head-body ratio of fetuses, and then of children, and then of adult, and you could appreciate the head-to-body ratio, and that's why we have higher cervical level injuries in younger children. Occipital cervical dissociations have about a 50% mortality rate. Younger age has higher risk. And you could just appreciate in this little baby who has a birth injury how big his head is compared to the body. And so that's unique in children. The neurological consequence of pediatric SCI varies as a function of age, injury, etiology, and skeletal maturity. And you see the younger children under 5 have cervical complete injuries. And as we go down, as we go up the age, we see more incomplete injuries. What's important here is over the last decade, we have seen an increase in tetraplegia in younger children. That may be due to better management at the scene, but we've also seen an increase in complete injuries in children. I added this slide last night after our pre-course because Bonnie Lee had a fantastic lecture on FES-assisted cough, and he noted that a primary cause of death in adults is respiratory failure, and indeed the primary cause of death in children is respiratory failure. And so there were wonderful lectures yesterday at our Steel Pre-course, and we look forward to some of these technologies that may mitigate, the effects of respiratory disease in children. And so there are some medical complications in children, and this picture is from a publication that was designed for village children, so low-resourced area, and it's a fantastic publication because it uses child-friendly language to describe all of the medical complications, and I just thought that was fantastic. But in children, the three most common complications are urinary tract infection, pressure injury, and autonomic dysreflexia. Importantly, in children, they sustained pressure injuries a little bit differently, and one of the most common ways is pressure injury from prone body mobility out of the wheelchair. So kids get out of the wheelchair, we teach them how to transfer onto the floor, and they scoot around, and it's a mechanism of pressure injury. Now, we do have a growing understanding that children with spinal cord injury are at a very high risk for developing early metabolic syndrome, although the magnitude of the problem is not well understood, and there's really no good studies in pediatric spinal cord injury about this. We do know that over time that children with C1 to 4 injuries, high-level tetraplegia, motor complete and incomplete are at the greatest risk for cardiac disease, and so we have some work to do in this area. Now, I am going to spend some time talking about musculoskeletal factors associated with morbidity and mortality in children, because I would argue that this is one of the most unique element of pediatric OCI, but also one of the most complicated. And so there's contractures, fragility fractures, but most importantly, the neuromuscular scoliosis and the pelvic obliquity. So upper extremity contractures happen in kids at the similar rates and trends as we see in adults. I would say that dynamic splinting followed by tendon transfers are very effective methods to reduce reoccurrence of elbow flexion contractures, and we should think about these interventions in children as we do in adults. Children under 5, however, unlike adults, are prone to developing pretty significant MCP extension contractures, and it's likely because the way they use their hands, and their MCPs are just stuck in extension. And we can reduce the tendency of these contractures by nighttime splinting and naptime splinting from the day of injury. And so the MCPs are placed in flexion, the PIPs and IPs in extension. And then the kids could go on and use their hands as they will, as long as we're splinting at nap and night. Lower extremity contractures, again, are similar as we see in adults. Stretching is really an ineffective treatment. There are surgical releases that we can do, but the contractures reoccur at a high rate. And really, in children, we only do surgical releases for those who are ambulating or have the potential for continued ambulation. Now, I do want to talk about neuromuscular scoliosis, and we had fantastic discussion at the Steel Pre-course yesterday, but neuromuscular scoliosis happens in most kids with spinal cord injury, anywhere from 91 to 98%. This is This is a review of children with neuromuscular diseases, if you will, and you could see that paralysis from spinal cord injury has 100% development of scoliosis as compared to some of these other diseases. And we do know with pretty good evidence that children who are injured before puberty are at 98% chance of developing neuromuscular scoliosis and 67% chance of going on for a spine fusion. And you can see that in comparison to kids who are injured after puberty. We also know that children injured under 12 years of age are 4 times more likely to go on and require spine fusion for neuromuscular scoliosis. So this is somewhat problematic because there are implications of neuromuscular scoliosis. In fact, it's really a great thing to have when you're a kid and when you don't have good upper extremity function, because we can use neuromuscular scoliosis in a collapsed spine as a compensatory mechanism to eat, dress, do body transfers, and to take care of perianal care. However, the problem is that in all children, neuromuscular scoliosis is progressive. And if you're injured before puberty, we see a gradual increase in respiratory distress, spasticity, slowing of bowel motility, scapular instability, and a risk for pressure injury. And so we also know, although we don't want to fuse the spine, we also know as the scoliosis progresses and it becomes greater curves, the complications of surgery are much greater. And so, so there's implications. So let me just, this is a quick illustration of how complicated this is. This is Jamie, who was injured at 7 years of age with a C5 level injury. Although she has a C5 level injury, she has fantastic functional electrical stimulation assisted wrist extension and grasp and release, and she's able to feed herself. But she does so using this compensatory scoliosis and somewhat of a collapsed spine. And her neuromuscular scoliosis progressed, and she had respiratory compromise, and she couldn't go to school and sit upright throughout the whole day, and she had new and frequent pressure injuries. And so she had a spinal fusion to arrest that progression, and she lost her compensatory ability to bring her hand to her mouth with this great FES system in her. And this just shows that before injury, she had about 40 degrees of abduction, and after surgery, she had about 40 degrees of abduction, but appreciate her elongated spine through the spine surgery and the loss of compensatory patterns. And then we don't understand fully what's happening with the scapula, but we think it's somewhat related or aggravated, but we certainly see scapular instability aggravated by a progressive neuromuscular scoliosis seen here. And so how do we manage this? We certainly use anticipatory guidance, and from the day of injury, we tell the families about progressive neuromuscular scoliosis. Watchful waiting is probably not the treatment of choice because children will progress whether they're sitting in a chair and not upright or walking, or whether they have an incomplete injury and they're walking. We could prevent or slow the progression using a thoracolumbar-sacral or orthosis or TLSO. Orthopedic surgeons or spine surgeons can put growing spinal instrumentations, and then we could have the spinal fusion with instrumentation. So what do we know? What's the evidence? Bracing may prevent surgery in 50% of patients if you begin bracing when the curve's less than 20 degrees. Bracing does delay the time to surgical correction, again, if you introduce the TLSO before the curve becomes 20 degrees. However, bracing has little or no effect once the curve is 40 degrees or greater, and these publications here show some of that evidence. So the TLSO is kind of it's a topic of debate and some ongoing feuding in pediatric rehab because it certainly improves balance. It could help with power chair control. It helps with respiration. It helps with total assist body transfers, and for some it assists with ambulation because it really supports the trunk. However, it interferes with ADL, and if children have the potential to develop trunk muscles, it interferes with them developing trunk muscles. It certainly interferes with manual wheelchair propulsion. If children are independent in body transfers, it makes it harder, and their reachable workspace is definitely lessened. Also, in warm tropical areas, children just don't tolerate a TLSO, and if children are prone to hyperhidrosis, they also don't tolerate the TLSO. And there's risks and nuances, so pressure injuries can be frequent if it's not put on correct or if it's not modified. It requires frequent modifications, so we're back into the rehab center. And it's amazing, even though you give instructions, you show pictures, you have a manual, they're put on the wrong way. And so that's a problem. So there are a lack of dosing studies on the TLSO. Some advocate that you begin at the time of injury when you don't even see a curve. And some of the prescription time is wear it while you're up in the chair to 23 to 24 hours a day. So we really don't know what works for who and why. We do know that regardless of the prescription time, the actual wear time is about 30% less than what you prescribe. So whether you prescribe 23 hours out of the day or just while you're up, it's 30% less than what's prescribed. So what we have to remember, the intent of the TLSO and pediatric SCI is really to delay surgery as long as possible to avoid early spine fusion. And we don't like to fuse a spine while it's still growing because it stops the growth and it's really associated with decreased lung capacity, and these kids already have some respiratory challenges. And so then there's a growing instrumentation system, and this is for children who, despite the TLSO, are progressing or when the TLSO is not feasible. And this surgically corrects the progression without fusing the spine. It requires lethaning's 3 to 6 months, every 3 to 6 months. However, after this, you have a spine fusion. This is not to prevent a spine fusion. And so just in this picture, these are the growing rods that are placed on the pelvis and the rib, and every 3 months you go in and you just extend the rod, and as the child grows, you just keep the spine straight and until growth, and then you fuse the spine. So the risks of these growing instrumentation systems, you have repeated anesthesia, there's a risk of infection, surgical wound, and autofusion. So often we see autofusion while we're trying to grow the spine. The benefits are that we could delay surgery and we allow the spine to grow. There are potential advancements, so there's non-invasive magnetic lengthening, so it's called the MAGIC system, where you don't have to do this surgically. So it decreases the risks of infection, but it requires every 2 months to come into the clinic for the growing aspect of it. Importantly, it always leads to a fusion, so we're not going to avoid a fusion with growing instrumentation. And so instrumentation with a spinal fusion, this is what happens after the growing systems. So it fuses the spine, as you could see, from the top to the bottom. It's into the pelvis. It arrests the progression, and it corrects the deformity. We know that it improves upright sitting tolerance and balance and respiratory distress. There's pretty good evidence in the literature. However, it removes any compensatory function for hand-to-mouth, perinatal care, or body transfers. And importantly, we have work that we're doing on diffusion tensor imaging and advanced neuroimaging in the pediatric spinal cord with the hope that we could classify pediatric spinal cord injury through imaging. And these types of kids cannot participate in any of our studies because there's too much metal artifact. And, that's a problem. There's also, it's not just go into the OR and fuse the spine. Often these kids have such horrific scoliosis that they require pre-op halogravity weighted traction. And so we slowly stretch the spine over time before they go in for their definitive surgery. And then, like I said, the surgical risks are high as the curve progresses. So we have pulmonary complications, wound infections, pressure injuries, dural tears, blood loss, aborted procedures, and then going into stage surgical procedures, pseudoarthritis, vision loss, and sepsis. And so this is a serious issue for pediatric spinal cord injury. And I would argue that this neuromuscular scoliosis, it's a conundrum for pediatric interdisciplinary teams. And so we all want the best for the child. But therapists are saying, well, there's so many detrimental effects of the TLSO. If there's a chance for muscle recovery in the trunk, they're not going to get a chance to do that. Their compensated functions taken away. You're just bracing the kid and making them stiff. And then the surgeons are saying, well, we don't want to fuse the spine until they're done growing because we don't want their lung capacity to be less than what we could achieve it to be, and that's a problem. And we don't want kids to develop high curves, and we don't want to operate when the risks are high. So we're really in a conundrum, and we have really not great literature, which we don't in any of our areas in pediatric SCI. Perhaps, though, fusionless correction of neuromuscular scoliosis could be the future. And so this is being done in adolescent idiopathic scoliosis. And so the concepts are intervene early, preserve motion, promote function, prevent complications, and eliminate metal artifact. And so this fusionless correction, if now I'm not a spine surgeon, my good friends are, but these are pedicle screws that are put in the vertebrae, and then you put a tether, if you will, through these pedicle screws. And what happens is that as the child grows, the tethering stops or slows the growth on this side and encourages growth on this side. And so you're actually allowing the spine to grow and slowly correcting that deformity as the spine grows. And so this is a child with adolescent idiopathic scoliosis with the tether, and appreciate the flexibility of her spine with this tether. I mean, it's real. Kids with adolescent idiopathic scoliosis can't do this after a fusion. And so this just shows you the mobility of the trunk that's possible with this tether. And so there is one adolescent with spinal cord injury as a proof of concept. She has a thoracic level injury, and you could see she has a 60-degree curve. And here she has the tether. This is pre-op, and this is 3 years post-op, where she's down to about 7 degrees of scoliosis. And what's important here, as I understand it, is that we don't try to achieve full correction at the first intra-op, because we want this not to be fully corrected, because we want it corrected with growth. And that's what the tether does, and it keeps a flexible spine. So this is before and after surgery with her pelvic obliquity. And then here's, appreciate, especially those who have worked with children with full fusions. Here she is with the tether, with fantastic trunk mobility, the ability to transfer in and out of her chair, pick things up from the floor, and rotate. And so this may, in fact, be the future for neuromuscular scoliosis. Also, what I'm excited about, it gets rid of all this medical artifact. It's so frustrating to exclude children from our studies because they have so much metal in them. I can't believe how many kids have so much metal, and so there's possibilities there. Hip instability is also, and subluxation is also unique to children with spinal cord injury, and you could see here that children injured under 10 are at much greater risk for developing instability of the hip. I think the data and the evidence is a little bit soft in terms of what works. There's a lot of different treatments. We don't know what works best for who and when to intervene. So, what constitutes success? And we talked about some of the complications. How do we successfully manage children with spinal cord injury? Well, we would all agree that we want children to be participating and satisfied as they progress through childhood and adolescence. But, we're always thinking about adults, and all of you who practice in adults, you'll inherit these kids. And so as adults, we hope that they're emotionally and physically healthy, that they're autonomous in their decision-making, their living, and their mobility. They're literate healthcare consumers because they're going to be engaged in the health system forever. They're employed or engaged in adult work. They're participating within communities. And most importantly, they're satisfied with who they are, where they are, who they are with, and what they do. And this really gets back to this issue of self-identity that we talked about earlier, and that's really our goal in pediatric spinal cord injury. And so when we manage kids, we want to engage them in activities that they need to do and want to do now at any age, and also activities that facilitate their transition into adulthood. And this is true whether children live in high region resource areas or low region resource areas. They're participating in activities that they need and want to do now, and what's going to move them through to adulthood. And so I'm going to talk briefly about mobility. And all I'm going to say is it should never be confused with walking. It serves a function for learning and exploration, and there's requirements of efficiency and independence. And we could talk about upright and wheeled. And for upright mobility, we think about a lifespan perspective. And we anticipate for the majority of children, especially complete injuries, that we progress from walking as they're little to wheeled mobility as they move into teenage. And wheeled mobility should never be confused with exercise. Again, it's functional, efficient, and it's cosmetically appearing. And powered mobility needs to be thought about as early as 7 months of age, and not only for children with tetraplegia. Children with paraplegia cannot push wheelchairs when they're 7 months of age, but they can use a power chair. And they, just like you wouldn't let a little 2-year-old be walking around independently, we don't let them use their power chairs independently. We supervise them. And so this is just real quickly how we think about mobility, not as, mobility is functional. So here's Alex, who has a cervical level spinal cord injury with his twin brother, injured at birth. Here he is at 16 months of age with his first power wheelchair. Here he is at 5 years of age with a manual wheelchair. And here he is with power mobility at 7 years of age entering first grade. Power mobility because the demands of mobility just changed going to school. Here he is back as a 9-year-old in a manual chair, 12-year-old in a manual chair, and here he is at 15 with a power assist. Again, the demands of function and participation has changed. Here he is at 17 in a power chair, playing sports, going to the beach, and here he is at 18 years of age with a power assist. That's what we think about when we think about wheeled mobility. More than just moving from one place to another, and we don't think about it for exercise or strengthening. Walking's important because parents always want their children to walk again. Every parent will ask you, but we think about it as integrated into a comprehensive rehab program for children with complete injuries. There's 2 systematic reviews and 1 scoping review on walking outcomes in children with spinal cord injury. So the studies show low-level design, case studies in series with a very high risk of bias, wide variation in sample. None of the studies followed children through puberty, and we need to do that as the growth spurt, and we see neuromuscular scoliosis. However, most studies agree and talk about the natural progression to wheeled mobility depending upon lower extremity strength, having a complete injury, body mass index, and environmental demands. And I just want to because walking is so important to parents, I'm not convinced it's as important to kids, but it is to parents. But just appreciate this comment here. 13 pediatric studies, 43 children, all but 1 were case series. Risk of bias was high in all studies. And so these served a purpose at one time, these case studies. We needed them to understand walking in kids, but I would argue they're not helpful anymore. Okay, I'm just going to keep going. And JJ, you'll just cue me if, right? I'll just keep going. Okay, I would argue that these studies are not needed anymore in pediatric SCI, and we have the tools and the outcome measures to do better studies with higher rigor. Because there's risks and pitfalls of walking, so pain, joint instability, fractures, Charcot spine, pressure injury, and spasticity, all risks of walking in children with spinal cord injury. Also, there is a guilt and a sense of failure that children and parents can experience of not pursuing recovery programs, the decision to stop walking, and the utilization of the wheelchair. And I would argue we need to mitigate or minimize those feelings. Upper extremity, same trends as adults, and my only point about upper extremity is that FES, nerve transfers, and tendon transfers should be considered for children as they are for adults. There's 2 excellent sessions at this program on tendon transfers. Those concepts are applicable to children. Children with spinal cord injury who have tendon and nerve transfers are able to become one-handed people again instead of obligatory two-handed people. And you could just appreciate, in addition to, these are before tendon transfers and after transfers, in addition to the really improved hand function, appreciate the posture during function that we're able to gain when we give them good hand function. Tendon transfers in combination with a catheterizable urinary conduit is great for adolescents, particularly girls. And if they have a TLSO for neuromuscular scoliosis, we just provide an access for self-cathing. And this really increases independence. People ask about whether tendon transfers have a long-term effect, and this is an individual who had tendon transfers and nerve transfers at age 12, and at 38, he's still very functional with them. And so children with tetraplegia should be considered for surgical management and reconstruction. I'm going to finalize my talk just by talking about two past challenges. We have been challenged in pediatric spinal cord injury by the lack of outcome measures that are relevant with strong psychometric properties. And that really impacted our ability to do good research. It's great to see that people yesterday when we had our pediatric pre-course, we understand that the ISCoS cannot be done in kids under 6. However, in preparing for this lecture, I found over 35 studies enrolling kids under 6 still using the ISCoS to characterize the sample and evaluate outcomes. And we know, for example, in this study, high rates of neurological recovery after pediatric spinal cord injury. Here's a 5-month-old, a couple 2-year-olds, and 5-year-olds, and they've attached an AIS. And so these studies are simply not helpful because we know they can't be done like that. And we need to really make them go away, if you will. We do have good measurement and outcome instruments, and these are some of the instruments that use in adult trials, and we have strong psychometric properties in children, and I would argue these are the ones that are recommended by NINDS, an international consensus that we should be using in pediatrics. And when we don't have measures, there's new ones coming about. Dr. Bierman talked about this yesterday. We have a neuro recovery scale coming out in pediatrics, and then we have the PDSI, which links scores across the lifespan. We have good outcome measures, and we have strong ones that are recommended by the NINDS, and we should all use that as a reference. Likewise, the ISCoS, the International Basic Data Sets, have been vetted for pediatric use, and there's no reason why we in pediatrics should not be adopting those basic data sets so that we could pool our data. And so the ISCoS in infants and preschool, homegrown measures, measures without psychometric support, and videos as primary data, we should never see in the literature anymore. They're not helpful, and we don't need to use them. If our commitment is to advance the field, we should be using the basic data sets so we could pool our data, and we should adopt recommendations by NINDS and other resources. We shouldn't be doing any case studies anymore in pediatrics. We have the ability to do multi-center studies. We have relationships, as evidenced by yesterday. We have global relationships that we could have powered studies, and we need to reduce the risk of bias. So here are the challenges to the field if we want to reduce assumptions and strengthen evidence. For clinician and practitioners, we really need to ethically use appropriate measures and standardize the collecting and recording of our clinical data. And we also need to have an awareness of clinical trial opportunities for children and refer them as appropriate. For researchers, we need ethical and appropriate use of measures. We need to recognize and reduce our own biases and the biases in our study. I mean, our literature in pediatric spinal cord injury is poor. And we need to monitor our outcomes through puberty and through the growth spurts, or else we're not going to be able to say much about the long-term outcomes. And then I would also challenge and ask sponsors, journals, and scientific associations to carefully review our submissions and our abstracts and select our studies when they're powered and when they're multi-center, when we use measurement tools and outcomes that are appropriate with psychometric properties. Look at our biases and take our studies and our publications that have as much least bias as possible. And then we need to be publishing on high-risk, high-gain studies to address the priorities of pediatric spinal cord injury. And so, again, this is not my work. This is the work of pediatric practitioners across the globe, and we've really come a long way in 18 years, and it's a real privilege. I do want to just acknowledge Randy Betts and Larry Vogel, Craig McDonald, and Scott Cozen, who have been fantastic partners in pediatric practice and my mentors. And again, my collaborators and old and new friends from across the globe, it's fantastic to work with you. I just want to acknowledge some of the funders who have supported some of the work that I talked about and put a plug in for the Steel Assembly that is a pediatric effort that is trying to bring people across the globe for education and research. And that's it. Thank you.